Now we'll start talking about some of these obligate intracellular bacteria. These are bacteria that do not grow or replicate at all outside of a host cell. This group of bacteria are all obligate aerobes, they are all intracellular, and they're all gram-negative rods. We're not going to talk about all of them because they're not all super common as human infections. We are going to talk about a couple of them because they are more common. But those of you who may be interested in veterinary medicine or those of you who have pets, things like Rickettsia and Anaplasma are fairly common infections in pets, in dogs. These are mostly going to be transmitted by insects like fleas or other arthropods like ticks. The genus Rickettsia is an intracellular gram-negative rod. Under this image here, you can see this is the eukaryotic host cell. Here's the nucleus. Here's all the gram-negative rods filling the cytoplasm. So this is an infected cell. Rickettsial infections are generally going to be classed as either spotted fever or typhus type of infections, and those are going to be the most common manifestations of Rickettsia infection in humans. You can find the bacterium in the cytoplasm of infected cells. When they are phagocytized, they will dissolve the phagosome membrane. They grow relatively slowly. The doubling time is anywhere from 9 to 12 hours. In infections caused by Rickettsia belonging to the spotted fever group, the bacteria are constantly released from infected cells. This can be contrasted with the typhus-causing Rickettsia, which will grow in number until it causes the cell to lyse. And then all of the bacteria will be released at the same time. So there are some differences in the way that these different groups manifest their infection. The spotted fever Rickettsia spotted fever. It's a fever and a full body rash. So this is one of those infections that can cause a full body rash. Hopefully you remember that syphilis, secondary syphilis caused by Treponema pallidum, can also cause a full body rash. In our virology section, we'll talk about a number of different viruses that can cause a full body rash. So while a full body rash is probably a really alarming symptom for some of your patients, it's also rather non-specific. So Rocky Mountain spotted fever is caused by the bacterium Rickettsia rickettsii. Even though it's called Rocky Mountain spotted fever, it is not isolated to the Rocky Mountain regions. We do have cases of Rocky Mountain spotted fever that can be diagnosed in California. It belongs to the group of spotted fever rickettsial infections. It has a protein called OMP-A, outer membrane protein A, that it uses to adhere to the host cells before being phagocytized. Rickettsia rickettsii is transmitted by hard ticks. Remember, we talked about those as being the ticks that feed for a really long time. In contrast to the borrelial spirochetes that cause Lyme disease, in Rickettsia rickettsii, an infected adult female tick can pass the Rickettsia bacteria to her eggs. We call that trans-ovarian transmission. So remember the tick life cycle, the hard tick life cycle. We have an egg which hatches or emerges into a larvae, which will molt into a nymph, which will molt into an adult. With Lyme disease, the larvae, when they hatch, they do not have Lyme disease. They do not get it from their parent. The larvae has to feed on an infected animal. When it molts into the nymph will then have the infection. But with Rickettsia, the female tick will pass the Rickettsia bacteria to her eggs. So when the larvae emerge or hatch from the eggs, they are already infected with Rickettsia, and they are capable of transmitting it to their host. In nature, rodents are going to be the reservoirs for Rocky Mountain spotted fever. In 2018, there were over 5,500 cases of Rocky Mountain spotted fever diagnosed in the US. This table here shows you a little bit about the disease itself. So it has an average incubation period of approximately 7 days. So following the tick bite and the transmission of the bacterium, approximately 7 days until the development of symptoms, which will include the abrupt onset of fever, headache, muscle pain, tiredness, nausea, vomiting, and abdominal pain. In approximately 90% or more of your patients, they will develop what's called a macular rash. This is going to be flat red areas on the body instead of raised rashes. They're going to be flat. And they have what's called a centripetal spread. So that means that the rash will usually start on the extremities and move its way inward. So you see like the patient's, looks like legs here, have the rash, and then it will move in towards the trunk. There generally is not going to be an eschar, which is going to be like a black necrotic lesion. And the mortality without treatment is anywhere from 10 to 25%. So what happens is this bacterium will get into the endothelial cells lining the blood vessels. That's what causes the rash, little localized areas of blood leaking. But it can also go to the cardiac system or to the brain and cause not only cell death because of continually leaking out of the cell, but also causing the immune system to come in and cause swelling and immune complications in those areas. Here's a map showing the incidence of Rocky Mountain spotted fever in 2018. So you see California is the lightest color purple. So we don't have a ton of cases in California, but we do have cases. The only 2 states that did not have any cases or that where the disease is not notifiable because they don't generally see it are Alaska and Hawaii. And even though it's called Rocky Mountain spotted fever, those of you good at geography, you know the Rocky Mountains are somewhere in here, right? Colorado, western Colorado. We tend to see the disease more frequently in some of these states. This is a series of patients who got Rocky Mountain spotted fever after working in the lab. So here's a 21-year-old vet tech presented to the clinic with complaints of muscle pain and a dry or non-productive cough. He was treated with penicillin and discharged. Over the next few days, he developed chills and a headache. When he returned to the hospital, he had a fever and a macular rash on his extremities and trunk. Intramuscular tetracycline was started, but he still had a fever. The rash evolved to petechia, or like really significant broken blood vessels on the trunk, the extremities, and the soles of his feet. He developed bilateral pleural effusions, and so then they started intravenous tetracycline, so into the bloodstream. Over the next 2 weeks, the effusions resolved. The patient made a slow but uneventful recovery. He was not working directly with the bacterium, but he had visited a lab that was processing it. So it's not really known how exactly he became contaminated, but it's the characteristic presentation, headache, fever, muscle pain, rash that can evolve into petechia or a spotted rash. So I want you to think a little bit about why penicillin may not have worked and what kind of treatment complications you would have when you're dealing with a solely intracellular bacterium versus one that might be extracellular as well. Rickettsia acari causes a disease called rickettsial pox. This is another one of the spotted fever rickettsial pathogens. Instead of being transmitted by a tick, rickettsial pox is most often transmitted not necessarily by mice, but by mites, M-I-T-E-S, associated with mice. So mites are little arthropods that feed on lots of things, including mice and including us. So mice are the normal host of rickettsial pox, but if they have mites and the mites bite us, we can develop rickettsial pox. At the site of the mite bite, your patient may develop an eschar. So you see that in this image here on the upper right, the black necrotic lesion. Hopefully you remember when we talked about anthrax, specifically cutaneous anthrax, that one of the symptoms there is also a black necrotic eschar. There was an outbreak of rickettsial pox in New York City in 2001. Hopefully you can appreciate the panic that set in New York City in 2001 when people, especially late 2001, when people started developing black eschars on their body. So rickettsial pox, the symptoms are going to develop 9 to 14 days after the mite bite. We generally will have an abrupt onset of symptoms, which include fever, headache, chills, muscle pain, and photophobia. So this is not a fear of light. This is light sensitivity. If you've ever had a migraine, you probably have experienced some significant light sensitivity. That's what these patients will experience. 100% of them will develop a rash. It is a papulovascular, so it's going to be more of a raised red rash. And it can be found really anywhere. The mortality rate in this case is fairly low, and this column here represents, did they develop an eschar? Yes. So here's our rickettsial pox in New York City. 18 patients who were diagnosed in New York City during a 20-month period after the anthrax bioterrorism attack in the fall of 2001. So again, the paranoia was high. Patients presented to the hospital because they had a necrotic eschar and were thought to have cutaneous anthrax. They had fever, headache, rash. They complained of muscle pain, sore throat, joint pain, and GI symptoms. Staining of the eschar and skin biopsies confirmed rickettsial pox, not cutaneous anthrax. These patients illustrate the diagnostic difficulties in recognizing uncommon diseases even when the clinical presentation is characteristic. Prior to the fall of 2001, physicians were not going to think, ooh, you have a black eschar, you have anthrax. They probably weren't really going to think rickettsial pox either. Well, what kind of infection is causing this necrotic wound? After the fall of 2001, doctors were like, oh yeah, that's anthrax. But it turns out, even though a black eschar is a fairly uncommon clinical manifestation of disease, when your brain is thinking anthrax, it's going to go anthrax, even though it's not always anthrax. And in this case, it was rickettsial pox. Another manifestation of a rickettsial infection, instead of a spotted fever, we could be talking about typhus. There are two different kinds of typhus that we talk about. Epidemic typhus or endemic typhus. Hopefully you remember from Bio 120, an epidemic is something that kind of pops up, gets to really high numbers, and then goes away, whereas an endemic infection is present at low levels all of the time. Epidemic typhus is not super common, especially in the United States. It's transmitted by human body lice. So again, you're talking about an infection that is going to be most common in places with really poor sanitation, where people are not provided access to clean clothes or to the ability to bathe themselves and prevent louse infestation. This infection was a huge concern during World War I and World War II. It killed millions of people. This also ran rampant through concentration camps during World War II, and in fact is thought to be the infection that killed Anne Frank of Anne Frank's Diary. Again, in the US, we don't see this super commonly. However, every once in a while, you can see a little outbreak of it associated with flying squirrels. So no touchy the flying squirrels. Epidemic typhus symptoms will develop approximately 8 days following the bite of the louse. Abrupt onset, fever, headache, chills, muscle pain, joint pain. 20 to 80% of patients will develop a rash. I know it's a really broad range. It'll be a flat rash, so not raised. And it has a centrifugal spread. So we talked about centripetal spread, where it starts on the extremities and moves towards the trunk. A centrifugal spread starts at the trunk and moves towards the extremities. It is not associated with the development of an eschar, and it has approximately 20% mortality if left untreated. Endemic typhus is far more common in the United States. It is transmitted by fleas, and we have recently had outbreaks of endemic typhus in homeless populations in Southern California. So warm, humid areas of the world, we tend to see symptoms develop 1 to 2 weeks after flea bite with a gradual onset of fever, headache, muscle pain, and cough. 50% of patients will develop a maculopapular rash, so a red raised rash, mostly on the trunk, not usually on the extremities. There is not going to be the development of an eschar, and the mortality is relatively low. In order to diagnose a rickettsial infection, microscopy and staining are useful to visualize bacteria in the tissue specimens, like a biopsy. Nucleic acid tests are not sensitive enough to detect the pathogen in the blood. We just don't have a good enough PCR yet. Culture is difficult unless you are proficient with tissue culture or eggs. These are obligate intracellular pathogens. They will not grow unless they are in a eukaryotic cell culture. Serology is pretty good. Western blots against the LPS and outer membrane proteins are going to generally be the way you can diagnose these. Treatment with doxycycline, fluoroquinolones, or chloramphenicol. Remember, these are intracellular bacterium. You must find a drug that will go inside of the host cell in order to eliminate the infection.